everybody. Thank you for the chance to talk about measles. I'm Jeannie Marazzo. I am a professor of medicine here at UAB, and I am the director of the Division of Infectious Diseases. I'll turn it over to Bill, and then I'll talk a little bit about why we think it's important to get ahead of this in Alabama today.
I'm Dr. William Curry. I'm also professor of medicine here at UAB, and I'm the associate dean for primary care.
Great. So just a couple of general comments about measles. Why are we concerned about this? A lot of people think it's just one of those childhood illnesses that happens to cause a rash and a fever, and it just kind of comes and goes. Measles is really a special infection, and there are a couple of reasons why. First of all, in 2000 or so, we were on the verge of eliminating it. In fact, the Centers for Disease Control said we had effectively eliminated it in the United States. The vaccine is incredibly effective. If you get 2 doses of it, you're 97% protected. And even if you're in that tiny 3% that can still get it, you have a milder case and you're less likely to transmit it. So it's a great example of us changing the trajectory of an infectious disease with a very effective vaccine. The other problem with it, and why you should know about it, is it's one of the most infectious agents we have in the ID pathogen world. So measles is so infected that it's estimated that if you take 10 people who don't have protection, have never been immunized, have never had it, you put them next to an infectious person, 9 of them, or 90%, will get infected. Why is that? It's spread through respiratory secretions. So if you sneeze, you are going to be spewing measles virus all over the place, and the really frightening thing about that is that it lives in the air for 2 hours after you sneeze it out. So it's a very tenacious pathogen. The next part about its infectiousness is that people are infectious 4 days before they get the rash and 4 days after the rash resolves. So it's an extraordinarily long time for people to be infectious while they are in the clinical state. And then the last general comment is, I mentioned that people think it's a benign kind of childhood rash disease. Unfortunately, really devastating outcomes are not uncommon, and they're more common in very, very young kids, less than a year, or people who are over the age of 20 or so. What do they include? We estimate that 1 in 1,000 people who get measles, kids, will end up in the hospital. 1 to 2 of 1,000 will die of measles-related conditions. Why do people die? Mostly little kids die because they get pneumonia. The other big killer with measles is encephalitis, which is a swelling of the brain. So if you look at 1,000 people who have measles, unfortunately, they're not just going to be the people walking around with a rash. They're going to be little kids who are more vulnerable to the bad side effects, particularly pneumonia and to brain swelling. The last thing I say is that I think, I've never seen a case of measles. Why? Because we were on the verge of eliminating it or eradicating it in 2001. So tons of physicians, nurses, healthcare providers out there right now have never seen a case. They really need to be aware of the epidemiology right now and know that if they see someone with a classic 3 C's, coryza, which is a runny nose, conjunctivitis, which is red eyes, and a cough, I believe. Now I'm probably conjunctivitis, coryza, and a cough. They need to really think about this with, especially in the setting of a rash, and know who to call and how to make a diagnosis.
So I suppose the next comment to make has to be why are we talking about measles today here in Birmingham? And that has to do with the fact that the incidence of measles is actually increasing significantly this year, and it's increasing nearby. So our surrounding states have had cases of measles. There's a report of at least 1 case adjacent to us in Tennessee, in East Tennessee. And the anticipation is that at some point the virus will cross the state line. It doesn't respect those imaginary lines, and so we're likely to have 1 or more cases of measles in Alabama. And the question would be, how well prepared are we for that? Certainly in terms of our public health infrastructure, and we did have a representative from the Alabama Department of Public Health who was to be here today but was not able to make it, but is supportive of what we're telling you. We have a very strong and effective infectious diseases control division within our Department of Public Health in Alabama, and we're very very fortunate for that. They collaborate with us in primary care and with infectious disease specialists such as Dr. Morizo and her division. So it's a very effective team, and they investigate outbreaks very quickly, again, in collaboration with the CDC. However, as Dr. Morazzo has said, it's a very infectious and effective virus, and once it gets started in a vulnerable population, it will spread quickly. So if we have people who are not immunized, if we have neighborhoods of people or clusters of people who are not immunized, who are vulnerable, then we're likely to see more than one case. We might see an outbreak. So we're trying to be very alert to that. Two ways to approach that. One is to make sure people who have not been immunized get immunized, and that would be important to do right now. And the second would be when there is a case for public health and others involved to engage in classic, effective case control public health so that we contain those cases. We've seen that work with other outbreaks of other viruses in the past several years. And so our public health people are prepared to do that. So part of what we're here to say is we want to urge everybody to be alert, to be aware that this is going on, to get immunized if they or their family are not immunized at this point, and to follow directions from public health if that happens, but also not to panic, that the people who are capable of having good surveillance over this are doing that, and they're watching closely and in collaboration with the primary care and infectious disease physicians of Alabama. We have a very good, close working relationship between all parts of medicine and public health in Alabama, better than some other states, and we're fortunate for that. So if Dr. Morazzo doesn't have anything else, we're happy to take questions.
Doctor, I guess first off, you had mentioned that this was essentially gone in 2001. Is there any singular thing that you can point to that helped allow this to come back?
Mm-hmm. Absolutely. So the initial influx of cases that then led to this successive cascade of infections was people who were unvaccinated from other countries come into the United States with active disease, and it started with people from Africa, from Eastern Europe. So really people who did not have the benefit of vaccination as kids coming into the U.S.
With the vaccine, you mentioned getting vaccinated. The MMR I know you normally have as a child. If you're an adult or an older child, can they still take that vaccine even now if they've missed that normal window, and will it still be effective?
Absolutely. So the CDC recommends that if you don't have evidence of vaccination or you've never had it and you were born after 1957, that you should get at least one dose of the vaccine and ideally two, separated by a prescribed interval. So that's perfectly safe. The reason we don't recommend it for people born before 1957 is that most of them were exposed to measles and have natural immunity.
One other population of folks who are not immunized are those who have reservations about immunizations. And that gets to be a controversial topic. But people have a variety of reasons, sometimes religious, sometimes concerns about the science or about the adjuvants in the vaccines and those sorts of things, whether those are safe or not. And I think it's just important to emphasize that the concerns about those, about the safety of vaccines and the chemicals that are in the vaccines, those concerns have been allayed scientifically very definitively in recent years. Some of the studies that claimed to show some problems actually had to be retracted because they were not true. And so people should feel confident that the vaccines are safe.
Is it possible to have an allergy, an allergic reaction to the vaccine?
It's possible to have a lot of things, and all of us can be allergic to things that we don't know about, but usually the reactions to the vaccine are very mild. Maybe, of course, soreness, redness at the injection site, perhaps fever, sometimes higher fever, and in young children, fever can go higher still, and that may need to be managed. But it's usually not a full-blown allergic response. I'll defer to Dr. Morazzo about the immunology of that.
Yeah, there are a couple, thanks for asking that question. There are a couple of contraindications to the vaccine. In other words, you should not get the vaccine if. And one of them is a history of allergy to a prior prior administration of the vaccine, if you have an allergy to an antibiotic called neomycin, very uncommon, most people wouldn't even know that. If you are severely immunocompromised, so if you're on a medication that knocks out your immune system for treatment of some other disease, and then pregnancy is a really important one. Pregnant women cannot get the vaccine. Pregnant women, it's a live vaccine. It's a live inactivated vaccine, and we don't use those in pregnant women because the risk to the fetus is way too high for any benefit. Nonetheless, if pregnant women get infected, they can be very, very sick, and there can be adverse outcomes of pregnancy like stillbirth, miscarriage, that sort of thing. So one other thing for providers to know is that if you have a pregnant patient who is not immunized or can't prove that they're immunized and they're exposed to someone with measles, they can't get the vaccine, but they can get a special antibody, an immunoglobulin, that's specific for measles. So be aware that that's available, and there are settings when we would jump in to do that to protect that woman and to protect the pregnancy.
And I just want to emphasize that those local reactions or a low-grade fever, that sort of thing, that's not an indication of allergy.
Yes,
That's
great point.
different from what Dr. Morazzo was describing.
Excellent point.
If someone were to get the vaccination several years ago, let's say like in 1960, do they need to get it again, or are they okay for life?
Now, that's a great question. We were just talking about that. The assumption has always been that if you get your first vaccine at 1 year and then you get your second vaccine between 4 and 6 years, that you would be immune for life. And we have never seen in the natural world evidence of waning immunity over time because we were eliminating it. Now with this coming back, I think it's a great question. We don't know. It comes up in pregnant women, which is what we were just talking about, because there are some data to say that as many as 1 in 20 pregnant women may have lower levels of protective antibody than we thought they should have if they were vaccinated when they were young. So there are some people who are actually testing pregnant women for antibody evidence of immunity, and that's something I think the CDC and the American College of OBGYN are discussing right now. But the short answer is we thought for a long time that it was lifelong immunity. We also know that pregnancy, though, to be fair, is a time when you are more susceptible to infections, and vaccination protection sometimes does wane in general. But I think it's a really good question, and the answer may not be as simple as we thought it was before.
Doctor, you're the director of infectious diseases. It's fair to say this is your life's work. Have you ever seen in person any of the symptoms of this, or do you know any of your colleagues who've actually seen this firsthand?
Yes.
Given where we were in 2000.
Yeah, great question. So I know, traveling in my infectious disease fellowship and my residency, I know no one who saw a case of measles because we always would share the classic findings. There's one physical exam finding that we always get tested on, and we all knew what that was. But I can say confidently that none of us ever saw a case. I do know physicians who are 10 years, 15 years, 20 years older than I who have absolutely seen cases. And Bill, you might want to comment on
The only
your own
case I've ever
experience.
seen was the one that I had because I was born before that magic year. But it is rare enough that, and it's an important point. And there are other infectious diseases, say like polio or mumps or others of that sort, that we see so infrequently or almost never. That it poses a challenge. Fortunately, the rash is similar to the rash of a penicillin allergy. Mm-hmm. So we've all seen that rash. We know what that looks like. So if you get that, plus the fever, plus the runny nose, plus the eye problem, the red eye and the cough, then it does. And now that we're talking about it, I think all our colleagues are beginning to think about it too. So awareness is really important, especially when experience is not as extensive.
And I would, I'm sorry, and I
I
would,
was going to say, did you say you had?
When I was a child, yeah.
Do you remember anything about it?
Not particularly, no.
I was just going to add that for providers who are on the front line seeing patients, the big reasons, as Bill just mentioned, Dr. Curry just mentioned, in terms of recognizing that constellation of symptoms is definitely to be aware, make the diagnosis, get public health involved, but remember what I said about infectiousness, right? So if you're in your office or you're in urgent care and you see a little kid whose parents said, well, I didn't believe in vaccinating them, and they come in with this presentation, put them in a room, keep them in the room, get a mask, make sure you're wearing an N95 mask, something to prevent anybody else who's susceptible from getting exposed. Also important to make sure your staff are protected. So getting back to the infection control measures and preventive measures, we don't have an antiviral drug that treats measles. There's no drug, which people find very surprising because everybody thinks we should have an antibiotic or an antiviral for everything. We got nothing for measles. So the only way we can really get in control of this is by prevention.
What happens with someone who, what is the protocol? How do you normally treat someone? Is it just to reduce the symptoms, reduce the fever, or how do you treat the measles, given that what you just said about knowing antivirals?
Sure, in my vast clinical experience, which I already referenced, what the books say is basically supportive care. So it's basically keeping people's fever down, being very watchful for those complications I mentioned. So pneumonia, encephalitis. I also mentioned otitis. I didn't mention this, but ear infection is not uncommon in little kids too, and deafness is a consequence of that. So it's really supportive care and being very attentive to try to prevent any of those deeper consequences from happening. I'm sure people are now looking at antiviral drugs, but everything would be in a very investigational
Yeah,
stage.
it's for severe cases and it's
Exactly.
investigational. Right. So there's one concept that we've alluded to that we haven't talked about. It's at least classically called herd immunity. And none of us maybe likes to think of ourselves as a member of a herd, but we all are, I suppose, one herd or another. And the idea is if enough people in that population are immune to an infectious disease, then it helps to protect everybody else because the virus is not getting passed around as much. You've broken the chain of transmission because you have 97, 98% of the population covered. When you drop below, and it varies by organism, but when you drop below that important number, then you've made it possible for that, what otherwise would be a small number of people who think they're immunized, but maybe their immune status is not quite good, they're vulnerable and don't know it. Now they really are vulnerable because you've introduced a larger group of people who are not immune. So that's the concern when you bring in, when people come in from elsewhere who are not immunized or people who are already here decide not to be immunized, you increase the risk to everybody, including those who previously had thought that they were protected.
And unfortunately, this outbreak represents exactly that kind of perfect storm, right? So you had, after 2001, these people coming in who were infectious, and then you've had a gradually increasing proportion of younger people who are not getting vaccinated. So those two things together have really created this opportunity for this virus.
Right, and that drop in vaccination rate has to do sometimes with something like a religious exemption, but that's very small. It's like 1 in 1,000 people in Alabama, something like that. It's more typically just maybe feeling satisfied that all is well and you don't have to worry about it because we've had this sense of security and safety, and so we take it for granted. And so there's that, plus then bringing in some other folks who perhaps are not immunized. So it's, in a way, it is potentially a perfect storm.
I think the other thing to mention too is that just every month or so another study comes out, as Dr. Curry alluded to, refuting the claim of an association between autism and vaccines. And in fact, just last week in the Annals of Internal Medicine, gigantic Danish cohort study of almost 1 million people who were vaccinated for measles and saw absolutely no association. So to the extent that you can reassure nervous parents, clearly autism is on the increase. People really want to help their kids not have anything like that. You really, I think, educationally need to try to reassure them that there is no substantial link. And as Dr. Curry said, some of the inciting literature about this actually did have to be retracted because of scientific inaccuracy. So recognize that people are very nervous about their children's health. We want to do everything that we can to help them have healthy kids. And from the science side and the public health side, we're very clear that safe immunizations are probably the best way to do this right now.
Other questions?
Can I get you to spell your names, please?
Sure, it's Jeannie, Jeanne, and the last name is Marrazzo, Marrazzo.
And I'm William Curry, Curry. Thank you.
If somebody wants to get their MMR vaccine, they can't remember if they were vaccinated or would like to get their child at this point, where can they get the vaccine?
Sure, that's available in most primary care practices, certainly at the public health department, and many pharmacies. So vaccines are available in a very accessible way these days.
And I would also mention another vulnerable group. Sometimes people don't think about it, and it's very important for Alabama because we have a lot of groups who go on mission trips. If you're traveling to an area where there is endemic measles because they don't have a great vaccination program, and you're not sure if you were immunized, please go to a travel clinic or to your primary care physician and ask about that. We give this vaccine in our travel clinic actually for that very reason.
I apologize if this was asked before. If someone is unclear if they've had the measles vaccine or not, is there any risk to essentially having it again if perhaps they mistakenly, out of their abundance of caution, want to do that and may have forgotten that they had it? Is there any risk associated with doing that?
There is not. I've had it, I think, 3 times for that very reason, mostly because I didn't have documentation of prior immunization. So there's not.
Is Tennessee the only neighboring state that have cases?
That's a great question. I think so. I don't think Georgia has seen a case, and I don't think Mississippi has seen a case yet. Who am I missing? Anybody else?
Well, Florida, but I believe
Florida.
there have been some cases perhaps there.
For populations.
Actually, there have been cases in Florida. I apologize. I just
Yeah.
did bring this out. So Florida, I think, is the closest one to us besides Tennessee.
Yeah.
Yeah.
For older populations who may have to have other vaccines like shingles or others, is the measles vaccine safe to take maybe a week or so after those vaccines are given?
Yeah, great question. Because it's a live vaccine, they actually, CDC and the American College of Immunization Practices recommends waiting 28 days between vaccines.
Right.
This may have been asked before too, but with the nicer weather out, people getting out, going to festivals, going out and getting in public, besides just being on the watch for people with those symptoms, what can general public do to help prevent themselves from being exposed? Can you wash hands? Can you?
Well, washing hands is always a good habit to have, and it may help some with this, but as Dr. Marazzo said, this virus is mostly a respiratory transmission, although if you have it on your hands, you can get it in your respiratory tract that way, but it hangs in the air for a long time. So it's really trying to avoid being around people who have that, and ideally, if you were, you would wear an appropriate mask to protect yourself, but most of us aren't going to walk around with that. So that's what makes it difficult. And it maybe brings together the point that the people who are at most risk are the ones who are in confined situations, not necessarily out at the festival, but in a college dorm, for example, in a military barracks, places where people are congregating close together for extended periods of time. That's where classically a lot of these outbreaks begin or get accelerated. And so those are populations where we need to take a close look at the immunization levels.
In fact, the airplane is the classic place, and there's actually a flight attendant right now in Israel who is in hospital with encephalitis from measles, probably contracted during airplane travel. So a great closed environment to transmit this, unfortunately.